Welcome to the Sedation Anesthesia of Pediatric Patients. I'm Dr. Gary R. Badger, Professor of Pediatric Dentistry at the University of Texas School of Dentistry at Houston. Today we'll be discussing the Module 2. I received no financial benefits that would create a conflict of interest or restrict my independent judgment with regard to the content of this presentation. At any time while viewing the video streaming course, you can take a break by simply pausing your computer. At the completion of this section, you will be asked to take a short exam in order to complete the requirements for streaming video courses. At the time, you will receive instructions regarding taking the exam. Section Overview. This section presents information to create an understanding of the continuum of sedation through which the dentist can make appropriate choices of pharmacologic agents that can be safely and effectively used for the various pediatric dental sedation procedures. This course is part of a 16-hour comprehensive program designed to meet the requirements of Texas State Board of Dental Examiners Rules 110.17. Sedation Anesthesia of Pediatric Patients. Today we'll be discussing Module 2, which is the physical evaluation and medical history of pediatric patients, including obesity, limited neck mobility, micro and retrognathia, Mallampati score, and limited oral opening. The images used in this presentation are taken from non-copyrighted sources in electronic media and attributed as possible. The de-identified images are provided as an educational resource to illustrate techniques and procedures for clarity. The objectives of this module is the participants should be able to evaluate the physical condition of the patient in order to determine suitability for sedation. And the second is understand reasons and factors that may affect sedation, such as obesity, limited neck mobility, micro and retrognathia, macroglossia, Mallampati score, and limited oral opening. To begin, we need to establish a focused physical evaluation, and the focus is on respiratory and cardiovascular systems in particular in a healthy child and other associated systems in a child with a complex medical history. The addition of laboratory tests, radiographs, and medical consultations may be necessary. The duration of the sedation anesthesia is affected by the examination functional results. The physical exam. The preoperative medical condition of the patient and the type of anesthetic administered determines the risk factor for its administration. Children without complex problems may need little more than a quick medical review. More complex histories will need greater scrutiny. The administration of anesthesia is a complex stress response affecting the respiratory and cardiovascular systems in particular, and other systems in general. Decreasing the stress response improves outcomes and limits comorbidity. The goals of preoperative evaluation. Number 1, documentation of the dental condition for sedation and anesthesia. So assessment of the patient's overall health. 3, determine if hidden conditions exist that affect the outcome. Let me digress here for a moment and say this is a really important factor, that in each consent form that we ask from the parent or care provider's guardian is to ensure that there may be conditions that have been undiagnosed in young patients. Conditions that the parent does not know about and maybe the physician doesn't know about, but should certainly be discussed with the parent. You can assess risk levels for patients based upon what you know, but you cannot assess risk assessments on patients you don't know if they have hidden conditions. It's really important to discuss this with the parents and let them know about this condition or let them know about the risk factor and make sure that they are fully on board with understanding there may be hidden conditions that no one knows about, and as the patient is ready to undergo sedation, that these hidden factors might affect the outcomes of the sedation, even to the point of morbidity and perhaps even mortality of the individual. Discuss this with each parent so they fully understand this concept. Number 4 is the perioperative risk determination. And this is what I alluded to in established risk factors. We know that it's possible to have hidden conditions and it will raise the risk determination, but under general conditions, when the patient's overall health is good, it's going to be probable that there should be no comorbidity challenges that face us as we do our sedation for this particular patient. Number 5 is ensuring the patient's condition is optimal for the anticipated treatments. And that means as we go through the physical examination and evaluation of the patient's health, we want to understand, and the parents understand, that the child is in great physical condition. Some of the mitigating circumstances of this might be that the child is beginning to develop cough or cold or upper respiratory infections that may affect the outcomes of sedation. It's important for us to understand that these conditions may preclude the opportunity for us to do sedation with the child, even up to and including the day of when the sedation activity is supposed to occur. If we find in the day of that something has occurred with the patient, perhaps between the day before and now, they could have had an accident, could have had a concussion, they could have developing symptoms such as a cough, upper respiratory conditions. It's important that this is not optimal for the anticipated treatments, and rescheduling is the best decision to make. Number 6 is the development of the treatment plan. The treatment plan is based upon radiographs, oral examination, extraoral examination, and an assessment of the patient's physical status. Once we have seen the patient's oral condition, we can then predict with certainty what needs to be done to bring this patient back to health. It's an important time for us to clearly establish and in some cases overestimate what needs to be done. For example, if we have a patient that comes in that has gross caries on a tooth and the radiograph indicates that they are sufficiently away from the pulpal tissue of the tooth, we may be able to suggest to them that we may possibly get into the nerve of the tooth and the pulp. If this happens, then the treatment plan will change. And therefore, in discussing this with the parent, we will say, let us give you the worst case scenario. If for some reason conditions change and the pulp tissue is imminently to be exposed, then we're going to add this to your treatment plan. If it appears as though we're not going to be into the pulp at all during treatment, once we discover that, then of course there will be no charge for this procedure. It's important to let the parents know that the treatment plan is a very flexible document, that we can account for those things that we actually see, and if there was an actual pulp exposure, we may know that, but during the process of removing caries, a pulp exposure occurs due to caries development, then it's important to know the parents have the assessment of the additional fee and they will be ready to take care of that. 7 is educate the parents about the sedation and anesthesia. What to expect, the expected care and postoperative discomfort to encourage recovery and relieve stress. It's important that the parents know the effect of anesthesia, what's going to happen. Is it going to put the patient down for a period of time when they're uncomfortable? Are they going to feel stressful when they get home because of the procedure that was done? And to educate the patients and parents clearly that postoperative discomfort is a consequence of doing sedation, and to encourage recovery and how to treat that postoperative discomfort and relieving the stress as well. The patients will obviously notice that the improvement of the patient's concerns and complaints about discomfort is being relieved by this treatment, and it may take a few days for them to feel comfortable with the resolution of this issue. Finally, to reduce cost and increase patient satisfaction. We want to ensure that the cost for the treatment is clearly understood, and then it's the patient's responsibility with their insurance carrier to cover those costs for the treatment that's being done. And finally, to increase patient satisfaction, that the issue of sedation and anesthesia has been addressed, the treatment has been taken care of, the patient is happy with the appearance and aesthetics of the result, and that the fee that was associated with this is a reasonable one for the amount of expertise that was placed in correcting the situation. The medical history. The medical history of the treatment is probably the most important one. Most important from the aspect that we need to know the health of the child and that they're in optimal condition to undergo this procedure, which has some risk factors associated with it. And therefore the history includes the past and the current medical history, the birth history, because the birth history gives rise to risk factors such as prematurity, perinatal complications, congenital chromosomal or anatomic malformations, and a history of recent infections, surgical history, family history, social history, allergies that may be present or may have developed, current drug therapy, unusual reactions or drug responses, and responses to previous sedations and anesthesia. Unusual or drug responses is something we should comment on here, because oftentimes many medications that we use in our regular practice result in reactions or drug responses that are unexpected. Unexpected because it is a child has not been exposed to these drugs or reactions prior to this sedation episode, and what it allows is that there might be an unusual reaction, an allergic reaction, for example, that has not been witnessed before if the patient takes this. And so it's important to us to judge that from the medical history. The past medical history includes previous hospitalizations and sedations. What was the outcome of that? How was the patient affected? Was it successful? Was it not successful? Birth history factors raise the issue of prematurity, and prematurity often have resulting respiratory issues that need to be addressed or at least taken into consideration because of the impending sedation episode. History of recent infections that may not have been on the history, and the consequences of those recent infections. Have they been taken care of? Are they completely resolved? Should there be a period of healing before we get in there and do some sedation for the teeth, which is entirely unrelated to the upper respiratory infection or possible approaching pneumonia or some other kind of condition? So recent infections need to be addressed and clearly understood. A complete review of systems to look for undiagnosed disease or inadequately controlled chronic disease or conditions that exist that have not been diagnosed by the family's physician. Diseases of the cardiovascular and respiratory systems are most important because those are the systems that require good fitness for sedation of anesthesia and reduce risk. A physical evaluation. The physical evaluation is a comprehensive, focused exam based on the child's or adolescent's age, the developmental phase, and the needs. The physical exam provides opportunities to identify silent or subtle illnesses or conditions that have been undiagnosed. It provides time to educate parents and the children about the body, its growth and development, and the interferences with proper growth and development due to nutrition, diet, things that are generally out of the control of the pediatric dentist who's about to perform this procedure. Also, the parents need to know their role in keeping their child healthy and providing for them the proper diet, the proper oral hygiene instructions to reduce the opportunities for further exacerbation of the oral condition. Physical examination includes an assessment of the airway, the lungs, and the heart with documented vital signs. It's important to take vital signs that can be assessed and tell us how the airway, lungs, and heart are functioning. Are they functioning as they should be? Is there a clear airway? Is there mucus occurring within the airway? is there been an upper respiratory infection which causes some hoarseness, that causes also some difficulty in breathing, and some healthy airway exchange and ventilation for the patient. The lungs, have they been damaged by prior incidences of lung infections? Perhaps croup when the patient was very young, when they developed this viral condition that results in hoarse voices, but also the croup sounds that needs to be taken care of. So a healthy lung is really important. And finally, the heart. Are there any congenital heart conditions? Has there been a murmur? Is it an innocent murmur, or is it one that's being affected over the long period of time for the health of the child, and they have to go in for regular visits to document what's going on with that? So the assessment of these three areas, the airway, lungs, and heart, with documented vital signs, important that we listen to the lungs, listen to the heart, listen to the airway as it exchanges air and carbon dioxide. It's important for us to know the extreme conditions that these systems have gone through prior to us embarking on the sedation road. Unexpected abnormal findings should be investigated before sedation and anesthesia. When the patient comes in and we look particularly at the lungs and the heart, if there are sounds that are going on in the heart that we don't expect, are there gallops occurring with this patient? Do they feel a sudden tingling with the way they may be getting some extra heartbeats? So it's important, if these were not detected before, if there were no limitations on the patient's activity or ability to perform regular exercise or climbing stairs, and issues that stress lungs and heart, we need to investigate what's going on with that patient, and that should clearly be delineated fully before we embark on sedation and anesthesia. Based upon the medical history, some lab studies may be needed, maybe a CBC, perhaps a chest x-ray. The values of the developing blood system, have they all been documented that we have the proper amount of hemoglobin that's available to carry the oxygen to the lungs? And ensure, and if we don't know, and if there's been some limitations on the patient's behavior, limitations on the patient's physical activities, then a lab study may be necessary. And a CBC would not be unreasonable, or a chest x-ray to take to see if the patient is completely healthy. So any limitations or suggestions that the patient is not in physically full health, it's important for us to understand what that is. Perhaps get a physical examination done by a physician prior to performing our sedation within the office. What medications are being used now? It should be documented, including herbals. We know that there is the possibility that herbal medications can interfere with drugs we normally utilize, and it's quite typical to expect that because many of the medications we have come from herbal sources, and so it's important to understand that the herbals that a family may be taking for their child may be additive and even supplement some of the drugs that we use for sedation. So if herbals are being taken, they should be discontinued 2 weeks prior to surgery until we know the full extent of that effect on the sedation. What are sedation and anesthesia risks? Well, the risk for sedation or anesthesia depends upon individual factors in the medications used. Individual factors, for example, mean that what elements that we do not have control over, such as the patient's health, can affect the type of sedation that we may choose. For example, we have long-acting and short-acting sedation agents. When we know that we're going to see a young child, we would prefer very short-acting agents if the duration of the sedation is sufficient for us to accomplish the treatment goals that we have established. If that is not possible, based upon the individual, then that's something that goes into the decision-making process of selecting the proper sedation agent. The medications used, are they having any effect on medications the child usually has? For example, children who have ADHD. ADHD is a condition that requires medication to control the attention span of the child, and generally those medications have an additive effect to the sedation agents we will be using to provide sedation of the patient, and to ensure that if those medications are taken, they may need to be discontinued or the dose not taken for some period of time before or after the sedation has been accomplished. The decision to provide sedation or anesthesia is made by assessing the risk of not performing treatment versus the risk percentage of the anesthesia. For example, if we have to decide the health of the individual is not optimal for performing sedation, but if we delay the treatment, then it may cause a problem. Let's take the example of a tooth that needs to be extracted. And the patient's cooperation might be a 2 or 3 year old that needs to have a tooth removed or several teeth removed, but the risk of sedation is such that it causes us concern. It needs to be determined if we don't perform the removal of those teeth that it could be at risk for the mortality of the patient, and it's important for us to decide it's worth the risk of performing sedation with a short-acting drug such as midazolam, then allowing these teeth to continue to deteriorate and perhaps the patient's health may become at risk for causing some neurological problems or even death. So we make that decision, and it's a choice between assessing the risk of not performing the treatment versus the risk percentage of the anesthesia. Patients with obstructive sleep apnea, or OSA, are at an increased risk of airway obstruction and respiratory compromise in the perioperative period. It means these patients who have been treated with medications for obstructive sleep apnea or the addition of continuous positive airway pressure is important to know, because in the perioperative, generally post-operative period, these patients need to be monitored much more closely than those patients who do not have obstructive apnea. We do know that when obstructive sleep apnea occurs, that patients stop breathing for up to 10 seconds and resume breathing. But in the treatment of patients with sedation, if they have obstructive sleep apnea, medications that have been used to treat these patients may interfere with the post-operative recovery period of time and result in increased periods of sleep apnea, which are not consistent with continued good general health. Sedation and anesthesia risks in patients with obstructive sleep apnea should be considered for special treatments such as continuous positive airway pressure applied appropriately after sedation and anesthesia. It may mean that the patient, until they're fully recovered and the lungs sound clear, it's important that we continuously provide pressure with airway and oxygen to ensure that this patient is fully recovered before we send them off. We have an article here about continuous positive airway pressure in the perioperative management. It's an article that's worth reading to supplement the information that you've been provided with here. Growth measurements correlate directly to nutritional status and can indicate whether a child's health and well-being are at risk. If a child is below the level of average growth, we need to be concerned that the patient's nutritional status may be causing this, and perhaps there may be some issues such as thyroid condition that is not allowing the child to grow properly, and so we look at averages when we're looking at children. Are they on task and on the growth development schedule to be right at the area that they should be? Are they in the 50th percentile or are they in the 10th percentile? And height and weight measurements can be recorded on growth charts. Tracking body mass index provides vital information about weight status and risk of overweight and obesity. The body mass index is an index that reflects excess body fat as well as nutritional status. Excess weight or obesity can increase sedation risk. By the same token, if body mass index indicates that the patient is at the lower end of the average scale, then we need to be concerned with, is this patient getting adequate nutrition to be able to supply their activity levels? Is it leading to improved growth and size and bulk on this patient if they're in the lower categories? So looking at the BMI is a very important way to assess the nutritional status and the growth pattern that's going on with the child, and we should be able to look at that. Basal body mass index for children and teens is a measure used to determine childhood overweight and obesity, as well as underweight. Overweight, which we are vitally concerned with in today's society in the U.S., is defined as a body mass index at or above the 85th percentile and below the 95th percentile for children and teens of the same age and sex. This website that we've indicated here is a way to see what those standards might be. Obesity. Obesity in childhood can be a risk factor for children that are being considered for sedation. Obese patients exhibit increased blood pressure, total cholesterol, low-density lipoprotein cholesterol, which is the bad kind, and triglycerides and low levels of high-density lipoprotein cholesterol. Obesity is a condition that affects every system within the patient's body. It needs to be clearly understood where the patient is. If they are approaching obesity and are simply overweight, it's the time to intervene and suggest to parents that some dietary alterations must be made to bring this child to a standard which reduces the risk of the patient, not only for this sedation episode, but for the rest of their life. Because what we do know about childhood obesity is that it will continue on into adulthood, and in fact even overweight children are predisposed to becoming obese as they get older and causing conditions such as diabetes and high blood pressure. Ensuring that we have addressed obesity clearly is a responsibility that we need to address with the parents at the time of listening or helping them with sedation. In 2012, for example, a retrospective study by Kang et al. Of 510 children found that 18% of obese children experienced adverse sedation events. This is what we're anticipating versus 12% of non-obese children. So events described were desaturation, and desaturation is when insufficient oxygen is carried by the hemoglobin to allow ventilation to occur. And if these obese children are having difficulty with that connection, it's going to result in a very difficult and perhaps an adverse sedation event occurring with the parents and children. Nausea and vomiting for children that are obese is much more common. In fact, dysphagia or difficulty in swallowing occurs a lot with children that are obese. And if nausea and vomiting results in dehydration of the patient after their sedation event, they're at risk for developing some serious neurological or mortality issues associated with that. Prolonged sedation may occur because many of the medications that we use to sedate children are what we call lipophilic, which means they love to hang around areas of fat and get themselves deposited within the fat molecules and fat cells, and eventually the removal of that sedation agent from the fat cells can occur. However, it can result in prolonged sedation of the patient once they leave the office. We think they're doing well, but we know that the lipophilic molecules are still in the fat cells and can result in some sedation when the patient is at home, and really true apnea, which means that the sedation agent is coming out of the fat cells, and when the patient is at home, they stop breathing because descending down the pathway to sedation again. So a high risk factor, and this study helps us to understand for obese children, it's critical to ensure that they are well recovered before they attend and go home. In a publication by Baker, another study on fat-induced restrictive lung disease and obstructive sleep apnea increased potential for respiratory complications. And so we know that if we have fat-induced restrictive lung disease, that is when you lay a patient down who has a lot of fat in their belly, it goes up and affects the diaphragm, which restricts the ability of the lungs to expand and get the adequate oxygenation that they need to be able to sustain the sedation that's occurring and to continue to bring the oxygen that's necessary to keep systems operating into the areas that they're needed by the simple mechanical reduction of the lung capacity, and results in obstructive sleep apnea and respiratory complications. Hypertension is more likely, and GI problems increase chances of aspiration, necessitating strict fasting requirements. Hypertension is high blood pressure, and it's more likely with GI problems to increase chances of aspiration if we have it very easy and dysphagia of the overweight or obese children, and are more apt to have episodes of nausea and vomiting, then throwing up and aspirating the contents of the stomach is important to understand could easily occur with these individuals, and it could cause us situations such as pneumonia or obstruction to the point of unable to breathe, and is a life-threatening circumstance. Making sure that strict fasting requirements are observed when they come in for sedation, particularly because of the relationship between the drugs of sedation are highly lipophilic, and in obese and overweight children increases the chance of a lingering sedation opportunity. Sedative drugs and dosages are based upon total body weight. For obese and heavy children may lead to oversedation. For example, if we had a 100-pound overweight child, and we would expect on the average that this child would be in the 50th percentile for weight, and this child is in the 95th percentile, then we prescribe medications based upon total weight. If we don't and are not observant of this condition, then it's easy to oversedate the children. So dosages should be based upon lean body mass, and they may also undersedate a overweight child or an obese child. So watching that very carefully, as adjustments have to be made in drug dosages based upon total body weight to avoid oversedating children that would be normally a smaller size. And also, if we adjust those dosages based upon lean body mass, we may undersedate. So it's a balance between looking what we should do, but being careful not to undersedate children, as well as to watch for oversedation. A very complex issue which one must pay attention to. The CDC recommends that health professionals use BMI percentiles when measuring the bodies of children and young people aged 2 to 20 years of age. Knowing the height and weight of the child and putting them on a nomogram, which determines what the average body weight would be, is something that we need to follow up on and use in the prescription of our sedation medications. Here's an example of a couple of individuals who obviously are on the obese side, and we could suspect that these patients may have diabetes, they may have difficulty in apnea when they're climbing stairs, they may have difficulty when they lay back and have to sleep on a pillow. But these are some of the kinds of things that we worry about when we're getting ready to sedate and provide anesthesia for these patients. Here is a 4-year-old that weighs 60 pounds, a very heavy weight for a small individual. And it's really important to note also that when you're looking at this obese patient, look at the ears of this patient. They appear to be a little bit unusual, and it should raise some concerns that this patient may have some medical conditions that are causing this patient to be obese. And so as we delve into the medical history, we need to be asking the parent, is this patient taking any medications? Has their thyroid been checked out? Are they eating quantities of food that are unusual for a child of this age? Have they spoken with their physician about their medical condition and the fact that they're overweight? Many parents know that their children are overweight, but they lack the resources to get in and have a diagnosis made as to what's causing this condition. So all of these things should be occurring to you when you see a patient of this physical size. It is unusual, it's not average, and there are associated medical conditions that develop when we have this condition present itself. These are height and weight growth charts, and the one on the left is for boys and the one on the right is for girls. These are very easy to obtain from the CDC. You simply go online and request the forms section, and in the forms section you'll be able to print these out. When you're treating children, one of the things that you should be aware of is the height and weight. Where do they fall on the scale? If we see the patients fall into the beyond 95th percentile, particularly boys, it tells us that this patient is overweight, and we should be adjusting these dosages that we have for these children so that they fall within a more reasonable range. Otherwise, we have a child who, again, talking about the lipophilic aspect of the medication, that these drug dosages will go in and stay in the fat cells, and when the patient is starting to recover, we think the patient's recovered, they've been in the office an hour after sedation is done, they seem to be awake and alert, and what we have not recognized is that these obese patients will have continued sedative agents within the fat cells and could possibly go home, go to sleep, and have a lethal situation arise. Girls tend to do better with their weight, but there are children out there, and the example that I just showed you is from females, and this is up to age 20, could be in their 20s, having conditions develop such as obstructive sleep apnea, and it's important to know exactly where they fall and advice from us on how to proceed. A review of the medical history or a review of systems is vitally important to ascertain is the patient at an optimal health level to be able to undergo the stressful condition of sedation or anesthesia. And that's general anesthesia or IV anesthesia. Either one of those two conditions, we have control over the vital features of bringing a patient to that situation. And it's important that we understand that we need to go through a thorough, focused medical history review, and obviously the two systems are respiratory system and cardiovascular system to understand what's going on. The vital signs, such as the heart rate, is important to know. Do we have a child whose heart rate exceeds the normal resting value? If a child is asleep, the value is at one side and it increases as activity begins. Is it beyond the normal activity rates, and why do they have that condition? Blood pressure is a factor also that as we look at the heart rate, because children have growing systems in their cardiovascular respiratory system, we know that they may not be fully developed, and certainly the lungs don't develop well until age 8, and so the breathing is at an increased rate. But blood pressure is another one of those factors that they may be higher than we need for that particular patient. And as we auscultate our patients, we can listen for those deep sounds of murmurs occurring within the cardiovascular system, and it's important that if we discover one, we can aid our MD colleagues by referring them for an evaluation and determination as to the condition of the heart. Can it undergo sedations and the stress that's related with that? Is there hypertrophy going on in the heart because of inadequacies of the musculature to be able to deliver the heart rate that's necessary to provide oxygen, hemoglobin, nutrition to those other systems in the heart and in the body? And is there congenital heart disease that's limiting the activity levels of our children? And oftentimes parents who have been visiting pediatric cardiologists can say that they've had some limitations put on their child's activity, but they really don't know why. And if there's no history, they have no medical records which show how they are functioning, it's important for us to contact our MD colleagues and get some reading on this condition of the heart. Is there a congenital condition that's causing this patient to be limited in their physical activities or limited in their diet? We need to know exactly what's going on physiologically with these patients so we don't enter into a situation that's going to result in neurological or lethal conditions. The physical exam is a focus on the airway and tonsillar hypertrophy. And as we look at that, there are two values, two standards that we need to look at in terms of rating the airway and tonsillar hypertrophy. It's important to know if that patient were to be sedated, if they were needing to be rescued by the introduction of an endotracheal tube. The Mallampati score is a way to determine, do we have sufficient anatomical space behind the tongue to be able to introduce a endoscopic instrument and place an endotracheal tube within the trachea to affect rescue of this patient. The Mallampati is a score that we look at and rate them, and as the numbers go up, if we see very little of the uvula, then it's a very high score up to number 4. If we can see the uvula totally with a large amount of space between the uvula and the surface of the tongue, then we have a very clear open airway that will allow us to insert an LMA if we need to do that, a laryngeal mask airway, or do some endotracheal intubation for that patient and rescue that patient. Particularly because children's anatomy, when we start to see them at a very young age, is truncated in its size compared to an adult. It's easier to rescue a patient, if necessary, over the age of 8 than it is a child who's 3 or 4 or up to age 8 because of the size of their trachea, and the position of that is much more superior and anterior than it is for an adult, which is much more posterior, and also resides between cervical vertebrae 5 and 6 rather than 4 and 5 for a young child. Respiratory rate, and what is the rate? Does it fall within the norm? If they are respiring at a higher rate than we expect on the average, then why is that happening? Is it because the patient may be overweight or obese, or is it because they have some premature birth history and that their respiratory system is affected and therefore it's working at a disadvantage and doesn't supply the oxygen for good ventilation? If there's abnormal anatomy, for example, a patient with Pierre-Robin syndrome or micronathia, shows us that if there is those conditions that has exerted itself and there may not be full lung development, it's important for us to investigate that and see. And perhaps some spirometry testing can be done to see how effective respiration is. And in cases of abnormal anatomy, such as Pierre-Robin syndrome, and we'll show you that in just a little bit, that these patients may not be respiring and helping the development of proper respiration for that child. The ASA status, or American Society of Anesthesiologists, rates patients in a 1 to 5 basis, and we prefer to sedate children that are in condition 1 or condition 2. Condition 1 is when a patient has no pathology involved. They have no medically associated conditions with their body and are in completely average health, in good shape, and can withstand an episode of anesthesia or sedation without risk. ASA2 is a condition in which there may be a metabolic condition or situation medically that is under control. For example, patients who have mild asthma, they're in the intermittent stage, and not persistent stage, but intermittent stage of their asthma, And if it's well controlled, they're using an albuterol inhaler, and it's a condition where the patient is going to be adequately cared for, and we'll be able to do a sedation event. If, however, we have a condition that's beyond that, that it needs constant, persistent asthma condition, and that persistent requires the utilization of nebulized treatment on a regular basis, they have to use their albuterol inhaler more than 2 times a day or more than 2 times in an hour. It's important to say that this patient's in a ASA category of 3, and it's not the type of patient that we want to risk by taking them to a sedation episode within our office or IV sedation that you're carrying out into your office. So watching this and making sure that this doesn't happen is important. Another condition that might be categorized as an ASA2 would be type 2 diabetes. It's the early stages, and the patient's weight may be controlled or their blood sugar levels may be controlled through diet or exercise or a combination, and they have little concern about this, and they're taking care of it quietly, and it mitigates the ASA category, and it would be a patient that could easily be sedated within the office, provided all other aspects of their physical health is good. We need to have the MD's contact number. If we have any questions when we're going through the review of medical systems, it's important that we have the MD's contact number and the cell number of that caregiver that we can call and get an immediate response into what's going on. The address, not only the physical address, but the email address, so that we can contact that caregiver. One of the responsibilities that we have when patients are getting ready to go to the hospital is to send to an MD our patient for a physical exam prior to taking them or admitting them to the hospital for care. It's important that we have contact address. Oftentimes physicians are as busy as we are in our practice, and trying to get them to fill out a approval form for the patient with a consultation so that we can go ahead and do sedations. And by contacting them directly, they are very agreeable to providing the information that we need so that we can keep our scheduled appointments and our sedations can go off without any problems. Blood pressure for children needs to be measured, and it's measured routinely beginning at about age 3. And it's done for that reason because scientifically we know that children that are 3 years of age, if they have deviations from average on the routine blood pressure, then we know that they're faced with the possibility of becoming hypotensive when they get to be older into their teenage years and go on to adulthood and have hypertension for life. With treatment, children at age 3, starting at their age, receiving medication for control of blood pressure, it's less likely that we will see these develop into full-grown adults with hypertension necessitating medications to control. So starting early, when they come to the office, it's a good thing when we are beginning to send them to the hospital or do sedation within our office setting that we have blood pressure measurements and that they fall within the norms. We also have standards that are out there showing the blood pressure, and it's important that our children fall within that category. Taking blood pressure requires the correct cuff size, and that depends upon the arm size. Practically speaking, correct cuff size equals the largest cuff that will fit on the upper arm with room below for the stethoscope's head. We take blood pressures with machines these days, and it's important that if we see an elevated blood pressure that we go back to the manual method, and that's using the diaphragm side of the head, the stethoscope head, to be there in the cubital area of the arm, and as we raise the pressure on the air on the cuff and then release that air, we can determine when the first sound that we hear appears, and that is the flow of the blood through the vessels, and the last sound that we hear through the stethoscope is the diastolic, and that's what we want to know. So the first sound that we hear is the systolic blood pressure, and the last sound that we hear is the diastolic pressure. And taking a verifying manual blood pressure is important for us to verify the machines. The machines are good, it takes a lot of the effort out of it, but if we see variations in that, we want to do a manual one and come up with the much more accurate blood pressure reading that we need to have. Blood pressure typically should be measured in the right arm of a relaxed seated patient and with the arm resting at the level of the heart. Blood pressure measurement by auscultation is the gold standard, and the invasive blood pressure by automated device correlates reasonably well with auscultation, with practical advantages of rapid measurement, remote from the child, and elimination of reader area. If the blood pressure is high, however, by automatic device, repeat by auscultation and use the manual method to verify. Blood pressure is classified by systolic blood pressure and diastolic blood pressure percentiles for age, sex, and height. If the systolic blood pressure or the diastolic blood pressure falls within that it is greater than the 90th percentile, repeat twice at the same office visit before interpreting the result. The normal blood pressure is the systolic and diastolic blood pressure are less than the 90th percentile, and we want to recheck in every year. If, however, with the new blood pressure values, pre-hypertension, systolic or diastolic blood pressure that's greater than the 90th percentile to the 95th percentile, or the blood pressure is less than 120/80 millimeters of mercury to less than 95th percentile, we can recheck in 6 months. So again, we can recheck in 1 year if it's normal, but if it's on the pre-hypertension level, we want to have them come back in 6 months and let us recheck that again. And body weight management as appropriate. If the patient is beginning to get a little on the heavy side and it's raising the blood pressure, we want to make sure that if it follows less than 95th percentile but greater than the 95th percentile, we need to make sure that we are following up on that patient. The stage 1 hypertension blood pressure for children, the subsystolic blood pressure and or the diastolic blood pressure is greater than the 95th percentile to the 99th percentile plus 5 millimeters of mercury. So if we know it's hypertension, it's going to exceed the 95th percentile but less than the 99th percentile plus 5 millimeters of mercury. We recheck in 1 to 2 weeks if they have that reading. If the blood pressure remains at that level on recheck, begin an evaluation and treatment, including weight management if appropriate. Stage 2 or hypertension, not pre-hypertension, but hypertension where the systolic blood pressure and or the diastolic blood pressure exceeds the 99th percentile plus 5 millimeters of mercury, we want to begin evaluation and treatment within 1 week and immediately if symptomatic, such as shortness of breath, difficulty in climbing stairs, etc. So it's important for us to have a pediatrician that's available. We don't want to be in the business of doing the blood pressure checks, but we can do it and refer when necessary. If we had, for example, a child who had elevated or hypertensive, pre-hypertension or hypertension that reports to us, and we have them come back in 1 or 2 weeks to recheck and they still have high blood pressure, it's important to be able to contact our pediatric colleagues that are in the medical side of the business and have them begin weight measurements and weight management and precautions being taken so we can get control of this blood pressure, particularly if the children are starting around age 3 or 4 and we know that we can preclude the development of hypertension as an adult by taking action early. Medical history or review of systems. Determine if the health history requires an MD, physical clearance prior to surgery. If OR is considered, then yes is the answer. It's also possible that as we consider sedation, that we might wish to have a recent physical clearance from an MD to check on. Oftentimes, parents with young children see their physician on a frequent basis, and we want to know when was the last time they had a physical. And if it's been some time since they've had that physical, then we may feel more secure, have the patient come for sedation, that we have seen a physical exam done in the past 6 months or even in the past year to consider. Psychological conditions may preclude hospitalization. For example, patients who are claustrophobic and don't like confined spaces, or schizophrenia, where they have some unusual feelings. It's important to know that if those conditions exist, it may preclude hospitalization for treatment under OR conditions where they may be put into some restraints to help keep them on the gurney while we're doing treatment there, or they may have to go for some examinations, some MRIs that necessitate them being in claustrophobic conditions. So evaluate those things, may preclude it. Talk to the parents about how the patient feels about confined to narrow or small spaces, particularly if you're thinking about doing sedation in the office and you use a papoose board when needed. If that's involving patients who are claustrophobic or have schizophrenia, it may not be the type of patient that we want to handle within our office, and also it may preclude hospitalization and treatments before we get ready to take those patients for their dental condition. Reviewing patients with their medical history, we want to ensure that the liver and kidneys are healthy and totally functional. And why is that? Why is it so important? It's so important because the liver and the kidneys are the site of metabolic processes that take care of the drugs that we use for sedation. If you had somebody who was in end-stage liver disease or end-stage renal failure, these are important to know because it means that the drugs that we use for sedation, in fact, even the drugs that we use for giving local anesthesia to the patients, are metabolized in the liver and kidneys. And if those organs are not totally healthy, then it's going to result in an abnormal effect on the patient's sedation. And it's important that we ensure that they're completely healthy. Oftentimes when you have patients come to the office, there are really 5 things that you want to know about the patient. If they're still filling out their medical history, you may be running behind and you want to keep up to date. And the patient comes back, or the parents come back with the patient, and they're still filling out the medical history. You want to know are the liver and the kidneys and the respiratory system and the cardiovascular system. And the cardiovascular includes any bleeding tendencies, any allergies that may go on. Those 5 things you need to know when the patient comes back, and they can continue to fill out those medical histories when you're seated if you're in a rush to have this accomplished, rather than having the patient who has picked up their child from school and come to the office, rather than lose that appointment time. Make sure that you have those 5 things under control as you continue to go on. It's also important not to ignore the medical history, but things like childbirth is a very important aspect to know. Did they have the average pregnancy time? And the question you might want to be asking yourself is it the average pregnancy time? Have they gone 40 weeks? Or is the child a preemie? Because preemies are subject to lung conditions. The lungs, when they develop at that early age, put some stress on them as they're developing, and they may develop conditions that will carry over into adulthood. And particularly as they pass through your office, when they are young and preschool and then school age and then teenagers, if you have to sedate them for any number of reasons, if they have developmental delays, recognize the fact that if they're premature when they come into the world, they are likely to have associated lung conditions that are still with them and being carried on over a period of time. Medical history review is really important. And in the standardized scale for children, all weights between the 5th and the 85th percentiles are considered normal. In order to determine that, we can look at a CDC web-based tool that calculates body mass index and the age and sex-adjusted BMI percentile. Here, what you see next to Woody is the form which we can submit through online through this website that you see here, which will calculate for us the body mass index, and we can see if the child is in the overweight and the obese category, and also calculate the blood pressure, that we expect the blood pressure to be increased in these children, and they pre-hypertensive or are they already in the hypertensive, and in the importantly treat immediately category for our blood pressure. So medical history review and knowing where the patient falls in these standards is very important for us to determine as we get ready to consider sedation for them, but also to help sort out the children that are coming to the office. Are they at risk or not at risk? Another factor for looking at the physical condition of the patient is limited neck mobility. And why is this important? Well, it's important if we have limited neck mobility that if we take the child to the hospital for sedation or general anesthesia, patients like Down syndrome patient have limited neck mobility as one of the parts of the syndrome, and they have atlantoaxial instability. If we have a patient who has been diagnosed with that condition, it's really important to know what restrictions that patient has. It may be that they do not have atlantoaxial instability, and if not, and you're worried about that, and the patient has restrictions on their activities, it's important to send them to the physician to check. And they can check that for you by having an x-ray taken, and the x-ray that you see on here has 11 millimeters of distance in the flexibility of the axial and atlanto position, and 4 millimeters is the acceptable amount. This patient with 11 millimeters is at high risk for deleterious effects because of hypermobility at the atlantoaxial site. And if that's the case with your Down syndrome patient, it's high risk to bring those patients in for sedation, and it might be wise to have this checked out before you take them in for surgery. Children with fusion of the cervical vertebrae cannot overextend their necks because of the fusion. I've had patients myself in the operating room, and the patient had a history of neck fusion due to some injury that occurred, and this was like an 8-year-old boy. And when this boy came in, and the anesthesiologists were appraised of this history of this patient, as they started to insert the intubation, they found out that it was very difficult to manipulate this patient's neck because of the fusion, and therefore it took an hour and a half to intubate this patient, and it was with calling an ENT physician who would be coming into the operating room and intubating your patient. Anesthesia couldn't make it happen, but this ENT doc was able to do that. So patients who have fusion of the cervical vertebrae, it's important to know that in advance if you're thinking about taking them to the hospital or doing sedation. Now, if you do sedation, oftentimes we think, well, we've got just a sedation here, we don't have to worry about it. But if the opportunity arose where your child became deeply sedated, into deep sedation, and perhaps needed rescue, and you had that patient in your office, you would probably not be able to intubate this patient unless you do this for a living like the anesthesiologists do. So noting neck fusion, important for us to put those patients aside, have them checked out, and take them to the hospital for treatments. Sedation with these children can have high difficulty with intubation, as I've suggested with the patient I saw, and if needed, and therefore they're at higher risk should airway insertion be needed. And that's the point of explaining to you about limited neck mobility. Down syndrome patients who come into the office, Down's cases, may have atlantoaxial instability, and it's often diagnosed prior to receiving dental care. So this would be one of the questions. If you see a Down's patient that comes into your office, asking the parent, have they been examined by the medical community to determine if they have atlantoaxial instability? And if that has not been done and you need to sedate these children, it's important that you have that done, or consider taking the patient to the hospital with the caveat that they have been examined, they do have the instability, and that they will take precautions in anesthesia to ensure that this patient's extreme flexibility at a critical joint doesn't result in paralyzed patients who come in as a result of your needing to do their dental care. So please be aware of this condition. Stabilization may be necessary for dental care with sedation. A 4 millimeter interval between the atlantoaxial bones appears to be acceptable, and as growth occurs, further x-rays are needed to see what the condition of it is. It appears to decrease with age. However, in some patients, it increases with age. So this is something you certainly need to put into your repertoire to be able to ask questions. Micro or retrognathia, these conditions, both of these conditions, can interfere with your plans for doing sedation. Micrognathia is a condition in which the jaw is undersized. It is a symptom of a variety of craniofacial conditions, sometimes called mandibular hypoplasia. Micrognathia may interfere with your child's feeding and breathing. You will be able to recognize these patients as they come into your office because of the diminutive nature of the mandible. And when you are examining the patient, this is one of the things that you should see. Oftentimes, patients who have Pierre-Robin syndromes, for example, will come into your office at a later age, and they will still exhibit some decreased jaw growth. And so as you see this decreased jaw growth, it should suggest to you that micrognathia may interfere with the child's feeding and breathing. And should it come up that this patient needs to be sedated for their treatment, it's important to understand that this could be a evaluation that precludes you from doing the treatment under outpatient conditions. Retrognathia, formerly known as mandibular retrognathia, is a condition in which the lower jaw is set further back than the upper jaw, making it look like a person has a severe overbite. This condition also affects the ability to intubate a patient. In patients who are difficult to intubate, we do not recommend that you do within your office setting, but take them to the hospital and be able to have that patient under the proper conditions and with rescue opportunities available to you, or the opportunity to evaluate this patient whether they will be good risks for general anesthesia or not. And it depends upon good proper anatomy, and micrognathia and retrognathia are not those conditions. We'll show you here a couple of examples of this. Here is a patient on the left that has retrognathia. This patient with retrognathia means that the lower jaw is further back than you'd like to see it. You would prefer to see the facial profile a little more straight, going from the nares down to the chin button, and in this case you don't see that. And so when you were to examine this patient, you would notice that you have a fairly sizable overjet, and this overjet is fine. It's the retrognathia that may not allow you to have intubation occurring easily within your dental office setting, and if you have an anesthesiologist coming, they may recommend to you do this in the hospital where you have rescue opportunities readily available. Remember that you're doing the Mallampati examination on this retrognathic patient, and what you might see with this is that you cannot see the uvula because of the size of the mandible. It hasn't grown ahead sufficiently to allow the tongue to be at a lower level, and you may have inadequate space to really intubate this patient. The patient on the right has micrognathia, and this is very much like a Pierre-Robin syndrome, where you have cleft palate, glossoptosis, and an inferior or retrognathia, micrognathia of the lower jaw. And so when you see that condition, those three things that form the triad and syndrome, it will be very much like this patient on the right. The lower jaw is very diminutive, well placed back. It doesn't allow the lower jaw to be brought forward sufficiently for adequate room to do intubation should that become necessary. Micro or retronathia. These are patients with micronathia or retronathia, have upper airway obstruction from retropositioning of the base of the tongue and compromising the hypopharyngeal space. When you look at this patient on the left photograph, the maxilla seems to be hypoplastic and the mandible seems to be quite protrusive. When you look at that patient's intraoral photograph in the center, you see that the maxilla is indeed retrognathic, and it does not allow the tongue to come forward sufficiently to get out of the way of the trachea. And so if you were to treat this patient for sedation, it would be a high-risk category, and the recommendation would be that it reduces the hypopharyngeal space and is a risk factor for doing this patient, and therefore it's not an ASA 1 or 2, and this would not be a patient you'd want to take. On the right side, you see the surgery that's been done, as they did a Lefort 1 to be able to get this patient's upper jaw forward, and by doing so, it opens up the hypopharynx area and able, if you were to do sedation on a patient like this, certainly want to question them. Did they have any surgery that affected their face? And if so, what was it? And if this patient had a maxillary advancement, it might be well to, if they needed sedation, to look at their throat and do the Mallampati scoring and the Brodsky score and be able to see exactly the nature of the condition. The patient in the lower photographs are one who was a young patient who had macroglossia, and the resection occurred to bring that tongue back into the mouth. Oftentimes when you have macroglossia, it could be connected with a syndrome, and if so, you'd want to investigate what the other features might be that make it a syndrome and see if you can work with that patient on an outpatient basis. If not, then going to the operating room and having those patients go there is the best answer for you. What are the effects of micro or retronathia? Patients with inadequate airway development may be difficult to intubate for anesthesia. If the evaluation of the airway indicates potential obstruction, then sending patients to the operating room for general anesthesia would be appropriate for a specialist physician anesthesia. Oftentimes we have pediatric anesthesia, and for patients who fall into that category, we ask for them to come with patients who have special syndromes because they are experts in pediatric anesthesia and not just the general, not to degrade the importance of anesthesia, but pediatric anesthesia, they deal with children all the time, just like we as pediatric specialists deal with children all the time and can anticipate and handle urgent and significant conditions of patients as they come in. When patients with these conditions present and sedation occurs, the relaxation of the surrounding soft tissue allows the tongue to drop into the restricted airway in the hypopharynx and obstruct, not only in that area, but also in the area that's not well supported. If you have an immature lung development, what you might see is that the lungs and the short distance between the tongue and the trachea obscures the ability to do good intubations, then this may not be a patient that you would want to do. Recognizing these conditions at evaluation helps to determine where the sedation can be done successfully. Here is a photograph of a Pierre-Robin sequence, and again they have cleft palate, they have very large tongue, and a retronathia condition. If you look at this patient on the left, it's an infant, and as this infant grows, you'll see that the mandible grows to improve how this patient looks, but the patient's still not fully developed in such a way that you would feel comfortable doing sedation in your office. It just depends on what you see physically when you do your examination on this Pierre-Robin sequence. Is it a patient you'd be willing to risk with sedation in your office? You have the oropharyngeal device that you can use intraorally to be able to help you out with breathing, but that's when the patient is going to be unconscious. That's not really how you want to treat patients safely. The Mallampati. The Mallampati is a way to classify the space that exists between the soft palate and the dorsal surface of the tongue. When you see this patient, you want to look, as you do in the class 1 patient, and see, there's sufficient space available there, and you have good neck flexion with this particular patient. You ought to easily be able to use your laryngoscope and depress the tongue, push it to the side, and visualize the glottis and get your intubation occurring. The class 2 patient might occur to be the same thing. You see that there's a difference in the 1 and 2 classification, and so the class 2 and 1 and 2 that you see, you might be able to do that. So as you're doing your examination on these patients, it might be a good idea to depress the tongue, take a look back and see what space you have available, and this is typically what you want to do during your examination. There's one time that you need to do that to be able to look at the patient, and be sure to look back there and see what's going on. Class 3 Mallampati score is where you barely see the uvula that's present there, and it's important as you look at this, what is the width of the pharyngeal area? Do you have sufficient space available when you depress the tongue? Do you have adequate space to be able to use a laryngoscope and do an evaluation of the airway to be able to get down in there? And it may be one that's just in between 1 and 2 and 4. And see, this is a class 3. How are you going to classify them? If you had to sedate them, it would be less risky to take them to the hospital, where you have the ability there to work with the patient when they're being breathed for by anesthesia. And certainly class 4, you see you have very little space available between the size of the tongue and the posterior soft palate. Would you be able to get an intubation into that area? And my guess is that you would probably be more successful if you took this patient to the hospital and let them know what your Mallampati score is, and not put that risk together with your anesthesiologist within your office setting unless they feel comfortable handling all emergencies and being able to breathe for the patient. Sedation would probably be not an elective that we would want to accomplish with numbers 3 and 4 easily, perhaps 3 depending upon the size of the pharynx, but certainly 4 would be very risky. This is the Brodsky tonsillar classification. Now, oftentimes people will talk about the Mallampati score as being the sine qua non, showing you how much space is available, but it is not a classification of the tonsillar class. And what Brodsky has done here is to give us grades 1 plus the tonsils. You look back in there and the tonsils appear to be within the pillars of the tonsillar area and without much issue in terms of obscuring what's going on. In grade 2, what you see is the tonsils are beginning to appear, and appear taking about 25% of the space between the two sides. Tonsillar 3 is a condition where the tonsils are very enlarged, and it may be a transitory condition that this patient has, and that the tonsils over a period of time will revert back to grade 1, but for this time, usually during the winter time when upper respiratory infections occur, you may see the tonsils enlarge if you have them to the point where they get to be grade 3, and this would not be a candidate that you would willingly do sedation of in your office, but might want to take this patient to the hospital to be handled under conditions where, should an emergency arise and you need to intubate this patient, that they would be able to do this with their team and while the patient is still asleep. Certainly grade 4 tonsils, and sometimes grade 3 going to grade 4. When you have an obese patient who has very large tonsils like this, they may have an infection that's going on in their tonsillar area, And when these patients go to sleep at night and they lay their heads down, obstructive sleep apnea could occur, and the tonsils close off the airway. And if the patient doesn't breathe well or is congested in the nose, the patient's going to have some apneic episodes. Sometimes they will start to do treatments on these patients that are large, and what may happen if you ask the parents, the sound that you typically hear when patients who have sleep apnea is they will have normal breaths that is occurring in and out of their mouth, like this. And then suddenly you don't hear anything, and then there's the catch-up breath, which sounds kind of like this, where the patient resumes breathing after about 10 seconds. And this is the condition where the patients, oftentimes parents are concluding from information from the teachers at school that the child is sleepy at school. It's because they have these on and off obstructive sleep apnea conditions, and they're not sleeping well through the night. They don't pay attention well at school, and their grades are slipping. And so if you have grade 3 or 4, it's a condition that you might want to refer to ENT. Here's obstructive sleep apnea that's going on. They typically have that when they come. They're always breathing through their mouth. It dries out the dentition. The caries rate, it goes extremely high. They are trying decongestants, which continues to dry out the mouth. And so you have a high caries risk situation with this patient. Very difficult to intubate should it be necessary, in a high-risk situation that's not likely to be handled very easily in your office, either by you or by the anesthesiologist that comes. So it would be wise to say, let's take this patient to the hospital where the patient will be sleeping and breathed for, with intubation occurring immediately after they get there, and allows them to do that while the patient is at lower risk. Physical evaluation, medical history. During the general review of systems, all things are taken into consideration. Review of systems, each system that has an impact on the health of the patient is one that needs to be clearly identified, and see what's being done. Are they taking medications for these systems? And are the systems operating well? Are there restrictions on their activity level? Are they being held back in school because of some medical condition that may impact doing sedations? So determine that as you're going through that. We'll talk a little bit more about the review of systems. As you remember, cardiovascular and respiratory systems are the key to having a successful sedation. And I prefer to say that respiratory systems would be number 1 on my list, and a healthy cardiovascular system supporting that. So if there's anything wrong with the respiratory systems, most of the difficulties come with inadequate ventilation when you're handling a patient. And so if you have inadequate ventilation, eventually the cardiovascular system is going to be involved to the point of the heart stopping, and you don't want to be there. So preventing respiratory conditions that are not amenable to continuing on with care for the patient are important for you to take care of, or else you're going to have cardiovascular involvement, and that's not going to be very successful for you. So determining the health of number 1, the respiratory system, and number 2, the cardiovascular system is very important. Following that, as we mentioned before, the kidney and the liver function are completely necessary for metabolizing the drugs we typically use for local anesthesia and sedations to be certainly intact. And the neurological and psychiatric evaluation is very important. And sometimes patients will come with these conditions already evaluated, but you do not know that that's the case. Patient may be bipolar, for example, and one moment the patient is happy and helping, and the next moment they're crazy with hyperactivity and wanting things to be done. And these patients need to be evaluated, and patients that are bipolar may not be good patients to sedate, because you never know which side of their psyche that you're dealing with. So psychological disturbances have been shown to be more common in patients with severe asthma than in healthy children. And that's because when they have reading difficulties, they are very unsure of themselves. They're not sure where they're going to get the next breath, and it's very important for them to develop conditions that make them very difficult to deal with. And it's important to know that at the outset. Is asthma treatable? Yes, it is. But if it's not under great control, it really creates a lot of anxiety with the patient. And in particular, they tend to have high gag reflexes. And when you're examining them and you're doing your routine depression of the tongue to look at the throat, they may reach up very quickly and try to grab your hands because the gag reflex area is very sensitive in these individuals. And as a result of that, they develop psychological disturbances that affect how they will behave in the dental office. In general, the review of systems is a thorough evaluation of the general health and medical history of the child, noting restrictions to activity, how the child appears, do they have age-appropriate behavior, what is the gait, are they limping, are they carrying some part of their body inappropriately, their language skills, and responsiveness to conversation. If they are not responding appropriately to questions that you ask, if they look to parents, for example, for support in the response that they're asking, you might ask them, what grade are they in? Are they preschool or are they in school? Are they in special school? If they don't know the answers to those questions, you have an idea of their cognitive, age-appropriate development. And if the responsiveness to conversations are inappropriate, then you may see that they may be age 4 or 5, and if they're preschoolers and they're age 4, and you ask them questions, they might know their name, they might know their colors. If they don't know any of that, and they're prompted often by parents, then you get inappropriate responses, and it tells you cognitively where they are at in their development. I need to relate to you a story about a patient that came to my office, and this patient came to my office, and for every question that I asked the patient, the mom responded saying, say hello, or tell him how old you are, or some prompting response. And what I determined after examining this child was that the child was not responsible for coming up with the answer. It was the parent who was providing those answers and prompts to the patient. And it was discovered after visiting with this patient over a few years that the child was being forced by the mother to be considered by the school system to be on grade level. And after the third repeat of the kindergarten years, the mother had requested that the child be mainstreamed for a significant period of time, but yet the child was unable to respond and go on and should be in the third grade and was still in kindergarten. They discovered, or the parent discovered, although we knew it by talking with the child, but the parent discovered that the child was indeed a special patient and was not progressing on a regular basis with the school system, and so she requested that this child be able to receive special treatment and special services, and the school system responded by saying that they couldn't do that with this child because the child had been mainstreamed for so long that those services were no longer available. So the point of this story is that sometimes parents are in denial, and what we can pick up, like responsiveness to conversation, is it age appropriate for cognitive development, is very typically what we understand about the patient. And if you see that isn't the case with the child that's coming to your office, it may be necessary to make recommendations to the parent to be able to receive evaluations that will determine is it age appropriate or not. If you come up along with one of these patients, it's impossible to try and have a successful sedation if the child is not understanding what's going on, because they may not understand what you're saying, they may not understand the questions that you're asking, and if they've been prompted all along, it's going to be difficult for them to come up with an answer on their own. So beware of these patients, and in the general review of systems, this is something that you will pick up on, knowing what appears to be average and what appears not to be average. The knowledge of medications is very important that the patient uses, and by going through a review of systems, asking the question, what medications are you using? Are they medications that are going to interfere with the sedation? We need to know about what that is. And if they tell us all those medications, sometimes they're embarrassed about providing answers to medications that may show that their child is psychologically impaired. And if that is the case, you need to really ask the probing questions, like, is your child on grade level? Do they take any medications? Do they play well with others? Are they having trouble at school? And this usually elicits a response that seems to be less threatening than talking about medications that they use to control the child's attention span, for example. Herbal contributions, what they're taking from herbal medications, what contributions do taking those herbal medications have? For example, I think you know that echinacea is a type of herbal tea that's available, and it tends to stimulate the immune system, so it's told. And if it's a stimulator and you're using drugs to sedate your child and the child drinks echinacea tea, you can see that it's not going to be compatible with your sedation. So asking about herbal medications that the patient takes is very important in terms of what you're trying to accomplish for this patient. And many patients these days take over-the-counter medications, and among those medications are herbal contributions. Patients with allergies, when you talk about contributions, if the patient is allergic, let's say it's in the springtime or sometimes in the fall when haying season begins here in Texas, we know that kids tend to have hay fever and asthma and eczema, and this is called the atopic triad. The atopic triad means if you have those three existing conditions, you have an effect on the IgE allergy response, and it may show that the patient will not be able to control these allergies because these three conditions are just a signal to us that their body is struggling with being able to take these prostaglandins in a way that's going to be helpful. So this would be a patient that you want to dive more into the history of this allergy condition. Do they have eczema? Do they have hay fever? Do they have rashes on their body that need to be treated with some kind of condition? So these kind of things in terms of knowledge of medications is very important for you to know prior to assigning medications for sedating children. Question the parent regarding classroom behavior. Are they on grade level? Are they repeating grades? Are they taking special classes? Do they play with others, or they prefer to be independent? Do they self-stimulate? Are these questions that may be less embarrassing to the parent than asking your medical history and going into that? But you may want to gently probe in that area if it's necessary to get an honest answer. Finally, cardiovascular and respiratory systems. Are they intact? Are they functioning properly? Is the child restricted from playing sports when he gets to be that age? Usually 3 when they try to start with cluster soccer. They have maybe some limitations. They can't do that at age 3. Why? Because we know that taking blood pressures at age 3 is something that tries to get us to find what the blood pressures are in kids. Are they appropriate for soccer? Is it the fact that they're cardiovascular? They may have hay fever, for example. Not a good thing when you're playing soccer. And cardiovascularly, the respiratory system's causing some compromises there. And are they able to climb stairs without getting out of breath? So these are all functional things that we want to know about in the general review of systems. The pediatric cardiovascular system is heart rate dependent. And it's important to know because it's heart rate dependent because of lack of ability to extend cardiac reserve. The heart is pumping fast, and it's pumping fast because they don't have the reserve that's available in the cardiac system to allow us to have some red blood cells that are available if we breathe at a slower rate. So as the cardiovascular system develops, the heart becomes larger, be able to accommodate. You have some preload that's going to be available for pumping into the next chamber. If the patient has sufficient red blood cells and is not anemic, and you don't have adequate hemoglobin to carry the oxygen. So don't be fooled by the pulse oximeter. It'll tell you that the hemoglobin carries the oxygen and ventilation can occur. That's true, but if they don't have enough red blood cells, even though it may say 95% of your hemoglobin, well, do you have enough hemoglobin? If you're anemic, you don't have enough hemoglobin, so it could be a compromised condition for your patient. The metabolic demand for oxygen is 60% greater than for an adult in children, partially due to the heart rate, which is very rapid, and the respiratory rate is also higher. As the child gets older, the heart rate decreases and the respiratory rate decreases. That's because they have more cardiac reserve, they have more blood within the system, and it's able to help with the cardiac reserve that's necessary when it's called upon. Hypoxia develops rapidly because of the lack of functional reserve, particularly because in the lungs they don't develop entirely fully to maturity until they reach the age of 8. So until they reach the age of 8, their respiratory rate needs to be higher because the size of the system is very small and it's not adequate for the child to perform at higher levels because of lack of cardiac and functional oxygen reserve. They just don't have it. So it's important to determine that and understand that until they reach age 8, when the heart is at the adult level, is it large enough to compensate for the functional reserve they need when it's called upon. Bradycardia is the opposite of a high heart rate, and that's the initial response to hypoxia. Let's say that we're using a patient that we've given some sedative drugs to, or maybe even mild sedation, and it tends to affect the regulatory system for the respiration that occurs, and also the brain where it controls the level of heart rate and respiration rate that goes on. And if so, it can cause a reduction in the heart rate. And if the heart rate goes down, then there's inadequate pumping of blood to the organs that need to be supplied, and it results in hypoxia. The high cardiac output results in high oxygen demand of the peripheral tissues as a result of fever or infection or stress, and maybe stress would be considered in the dental environment that might be occurred. But if you have a patient that comes in that's had a URI and they have some other thing going on, they have an infection, plus the stress of coming to your office reduces the amount of oxygen that's available in the peripheral tissues, and it allows the cardiac system to go into a state of greater pumping ability, and because there are limits on the pumping ability of the heart to provide this system that brings oxygen to the tissues, not only are the lungs and the heart affected, but other tissues are affected as well. And so systems may be stressed to a higher level, particularly when you're doing some sedations. And recognize that the whole system is tied together, and it's important to ensure that we take care of the systems that are in healthy conditions, and any compromises to the system, cardiac and respiratory system in particular, at younger ages can be compromised. The lungs are not fully mature until age 8, I think we've mentioned that, and we have limited pulmonary reserve, and that's because the lungs haven't achieved the size that they need to have, so it doesn't process as much of the oxygen as it would if it did at a later age. Here is a diagram of the heart, and we can follow very closely that the heart is in the process of pumping blood, and the blue is where the unoxygenated blood comes back down into the right atrium and down into the right ventricle. It's pumped up into the pulmonary artery to the lungs. It goes to and through the lungs, comes back to the heart and the left atrium and left ventricle, and the oxygen-rich blood is left to flow back out to the organ systems that need it, particularly the brain, the heart, the respiratory system, kidneys and liver, and generates the whole system, but we have to ensure that the cardiovascular system is fed well with appropriate levels of blood and with the oxygen coming through the respiratory system to be able to feed the system so that it will continue to operate properly. The take-home message of this discussion about review of systems is that things have to be healthy and that the children that are smaller are working at a high level, and that high level is using up the oxygen in the blood system to be able to supply the vessels and the organs that need it. However, until their development occurs and gets to a level of maturity, the oxygen reserves are used up quickly. They have very little oxygen reserves, and when they're used up, we're going to go into a hypoxic situation, which results in cardiac involvement, and the flow that you see, the interferences with the oxygen or exchange or delivery becomes life-threatening very quickly. And understanding that means that while we are evaluating our patients during the sedation, if we see any deviations where the pulse rate goes up and it goes up in a trend fashion, we know that it's trying to compensate for the inability of the hemoglobin to deliver the oxygen to the lung system. And if that's a compensation that's going on, we're going to rapidly run into a very tired child whose cardiac condition will begin to tire out, and when it does, it's going to go into bradycardia and eventually cause rhythm changes that can lead to cardiac arrest. So looking at this diagram down in the bottom where it says obstruction, obstruction occurs when tissues relax due to muscle relaxants of the sedative drugs that we have, and apnea may occur. And when apnea may occur, it's going to go into laryngospasm. Laryngospasm is caused by accumulation of secretions in the lung field, but also due to the inability to have oxygen driving system going on, resulting in bronchospasm, where the lungs down in the alveoli that are exchanging oxygen for carbon dioxide are not working properly. You have the tracheal tree, which has gone through laryngospasm and perhaps maybe broken by good oxygen additions. But bronchospasm occurs when the smooth muscle vasculature is being impaired. When it's impaired, it tends to squeeze the bronchioles and doesn't allow exchange of oxygen, and so the ventilation system is going down. And when that happens, you have hypoxia. That means that the carbon dioxide levels are building and the oxygen delivery system is inadequate, and this results in bradycardia and heart effects. And that bradycardia, unless it's reversed, we're going to have some arrhythmias and it's going to be a lethal condition. So the take-home message is we need to start with a healthy child, be constantly monitoring what's going on with the patient, and if the patient has any risk factors at all, we need to make sure we take them to the hospital system where they can be taken care of with a rescue system immediately available. The other side of that coin is if you're comfortable handling cardiac and respiratory issues with a rescue, and you need to be if you're planning to do level 3 sedation. If you working with a healthy child, you're in pretty good shape, but if a level 3 sedation occurs and the patient goes into level 4, they get into deep sedation, and you have to jumpstart the heart. If you're qualified to do that, you're in good shape. If you're not, then you're going to be risking your life and career in that situation. So don't go there, be there, listen, learn yourself. It's important to understand that we, as we develop this course, are trying to provide you with the resources to be able to take care of patients, not only at the level of permit that you are looking for, but also if that patient descends into the next level. And if that patient descends into the next level, you need to be ready to handle that next level and keep that patient alive until EMS arrives there. So my advice to you at this point is to ensure that your team is well trained to handle emergencies, because remember, you need at least 5 people to run a team, and the captain of the team is you. And if you don't know how to run that team and assign positions and jobs and train those sources, you're putting yourself and the patient at risk, and everybody in that situation is going to be disappointed in the outcome. So please learn this, study it, understand it, be ready to handle emergencies. Take your pediatric advanced life support, take your ACLS, and make sure that you are the one that's going to be in the captain's seat and are able to deliver a result from this cardiac arrest. The patient history and evaluation continues to go on, and one of the things we need to know about is that the bronchus, if you look at the top section, you'll see the cross-section of tracheal tube or bronchiole, and the cross-section shows the size of it. And the cross-section can show also that this lower right-hand side with the gas exchange, where CO2 is being given off and oxygen is going into the bloodstream, it's all controlled within the lungs. And if the lungs become unhealthy, if they have any infection that's going on, we certainly want to be in a position to make sure that oxygenation, ventilation is occurring, and that the patient can be healthy. Childhood asthma is one of those conditions that compromises the respiratory system. The symptoms we see from childhood asthma is that we have some wheezing that's occurring, and that's a whistling sound when you're breathing. It's kind of a high-pitched sound, and when the patient has a lower respiratory situation going on, and wheezing usually occurs when you hear some gurgling or sounds of liquid in the breathing, that the patient might have a upper respiratory infection that's gone down in the bronchioles, and the bronchioles are trying to struggle with an infection going on, and it's the sound that you're listening for. It's high and it's sort of gurgly. The coughing is persistent because there are secretions down in the lungs and the patient's trying to get those out. Is it periodic? Is it persistent? Determining where that is going. And so if a patient has persistent, or let's go and talk about periodic. If the child has periodic exacerbations of the asthma and they have an inhaler and the albuterol inhaler can handle that, then it means that it's a ASA1 condition if it's mild, and that this patient would be a good risk for doing sedation. If, however, the asthma is persistent, and persistent can be mild, moderate, or severe, and if it's persistent means they're using their inhaler multiple times during the day, they have nebulizer treatments in the evening, they're taking corticosteroids to reduce the inflammation within the lung tree, it's really important to understand that, and that wheezing may occur in the lower airway, and when it occurs in the lower airway, we hear this whistling sound. So if you hear that on auscultation, it's really important to see that, number one, the patient's probably rapid breathing, and they have labored breathing. This is exhausting to the patient, and it's important that we make sure that this patient is not only breathing well, but exchanging and ventilation is occurring. And eventually they're going to tire. It's going to be very difficult. This happens with asthma, and that's why asthma patients tend to be a little bit neurotic about getting their breath in or coming to confined spaces, because getting their breath for them is like an everyday emergency. And they have this anxiety that if they should start losing their breath, you know how you feel when you can't breathe. You feel like you're smothering, and that's how these patients feel. And they complain of chest hurting because they have this issue that's going on with them. They're breathing very rapidly and the lungs aren't operating as they usually do. And you've got this whistling, wheezing sound. They have reduced energy, and you know how you feel when you've been out running and you come home and you feel like you need to lay down and go to sleep and take a nap, and that's because you have reduced energy. You've used all the residual energy fields within your body, and this is the same with children that have asthma. They tend to have baggy eyes, droopy eyelids, because they've lost all of their energy just being able to breathe, and they feel weak and tired all of the time. Generally tend to fall asleep in school, don't do well. They look like they just got over an illness. And so it's important to recognize patients with asthma are patients that you want to be very careful with, because the disease really is the lung tree, and that's the first step to going downhill. Risk factors are allergies. Allergies that occur in children that have asthma not only have asthma, but they have allergies to perhaps medications. Let's say they have an anaphylactic allergy. Their lungs are already compromised, and so you have to hurry very fast to rescue this patient, because they have a compromised respiratory system to begin with, and now they have an allergy. They may have taken something, like they're allergic to a food, and suddenly you have an anaphylactic reaction rather than allergy reaction. And so if you have an anaphylactic reaction, how is that different than an allergy? Well, we determine that by looking at the patient. They're having difficulty breathing, and suddenly we look and we see suddenly there's a rash on the patient. So we have an allergic reaction going on and a dermatologic action going on, and so we're likely to have an allergy. And so you start out with the albuterol inhaler, and once you start off with the albuterol inhaler, you know that you have something significant that's going on. And if it doesn't help with the albuterol inhaler to correct the asthmatic situation, and you see that you may have a rash developing as well, then you have likely anaphylactic reaction, and so you need to start with epinephrine, the 1 to 10,000, 0.1 milligrams per kilogram, and if you use that, and it's going to bronchodilate the patient, but it's also going to help the heart in its pumping factor, because it affects alpha and beta, and those instigations for starting a harder heart rate and a greater pumping ability is going to be important in rescuing this patient who not only has asthma but has an allergic anaphylactic reaction. So if there's a family of allergies and or asthma that's in the family when you're reviewing the systems and reviewing the histories, if you have that, oftentimes the patients are predisposed to having asthma and you don't know what causes it. But we can tell that patients that are preemies, that are low birth weight, often have respiratory system interference, and so it doesn't allow this to work very well. And if the patient is in a home that has secondhand smoke and it occurs before and after birth, we know that it predisposes the patient to having asthma and respiratory effects growing up with that. And it occurs mostly in growing up in low-income urban environments, that these patients, many of the patients, have parents that are smoking, or they have not been able to get in because of their low income to have regular visits with their physician to ensure that they are perfectly healthy. Then this means that this patient is a higher risk for getting asthma, and because they live in an urban environment where toxic air particles are coming in on a regular basis, it makes growing up with asthma and having an inappropriate or undeveloped respiratory system makes them at higher risk for developing that. And that increases the risk when you're talking about patients who have asthma. This is an asthma classification, and it's really a good way to look at how the combined types of asthma occur. If you look in the left-hand side, you'll see components of severity and when impairment occurs in risk levels. And if there are symptoms, it can be nighttime awakenings, short-acting beta-2 agonists, use lack of controls for the prevention of sleep apnea. And if we look over here at the classification of the severity of asthma, we see that we have the intermittent symptoms of these patients that have asthma, and it's when twice a day, if they use their inhaler, then this is something that causes them to wake a couple times at night. And if it happens only on an intermittent basis, let's say this week, and I've had patients go as much as 2 or 3 months, sometimes they go as much as a year, they haven't been able to use their inhaler, they don't have their inhaler with them, and that's a good point to think about when you have a patient who's classified as asthma. Make sure that they come with an inhaler, and certainly in your emergency cart, you want to have a container of albuterol that they can take a few puffs with. If you have a patient who has asthma and they're classified as mild, moderate, or severe, and the frequency of taking medications or the utilization of albuterol and of using a nebulizer, the more frequent, and the use of corticosteroids, if they're getting all three of these things, then they tend to be severe, and they get them throughout the day that they're having symptoms. Or is it daily they're having symptoms, or is it a couple of times a week? So if you know and ask those questions, when was the last time you used your inhaler? You can determine, okay, did you use it twice this week? Or did you have to use it every day? Or is it throughout the day? And I've seen patients come into the office and they're sitting in the waiting room and they're taking a little sniff before they come in, even though they may not be getting nitrous oxide. So if it's just once or twice a day, that's okay. It's mild, and this would be an ASA2. If you get to the moderate and severe levels of asthma classification, then these are patients who are using high-powered medications. Corticosteroids, for example, when they're taking it on a regular basis, decreases the endogenous corticosteroids that are being developed. And so if you were to bring in a moderate to severe patient who has asthma and they've been taking corticosteroids regularly, you need to think about boosting their steroid level. And some people recommend you take 60 milligrams, like the week before the patient comes in to see you, and also like the night before they come in to see you, take an improved dosage of the corticosteroids, because they need a bump in their emergency endogenous system, and it's important that they do that if they're coming in and using these drugs on a regular basis. So this is a good chart for you to look at, to study, and show you what it's like for patients who are having asthma and how they need to be classified, and get it clear into your head how you need to be ready for these patients when they come to your office that are aged 5 to 11. Children are at increased risk with respiratory adverse events in intraoperative and postoperative situations. They could have active or recent URIs within the past 4 weeks. If you ask that question, when was the last time you used your inhaler, you can say, well, they use it once or twice last week, but that's it. You want to inquire if they have a runny nose, they have an upper respiratory infection. What is the character of that runny nose? Is the runny nose like a clear liquid that keeps pouring out of the nose every day? If that's the case, then it's a very easy case to treat. You put them on some antihistamines and it'll tend to stop the nose running. If, however, you see green gunky material secretions coming out of the nose, or that they're coughing up, then they have some real impediment into the exchange of air, and ventilation may not be occurring. If it's happened within the previous 4 weeks when they come to your office and they need to be sedated, you need to reschedule them and give their airway a chance to heal up before you consider doing sedation. If they have a history of reactive airway disease, and reactive airway disease is really a definition of, we don't really know if it's asthma or not. Usually by the age of 3 they have that diagnosed, but if it's before the age of 3, we know that preemies tend to have reactive airway disease, and their lung system hasn't matured adequately, and so if they're having asthma-like symptoms, they call it reactive airway disease until it proves itself with a little more evidence that it is really asthma, and if so, they can be placed on regular medications that will help with asthma. But until that time, it's reactive airway disease. If you have a patient that comes in to visit with you at the office and it appears as though they have reactive airway disease, they're going to be younger than the age of 3, and there's a history. And oftentimes parents will relate to you, oh yes, we're getting treatment right now. You don't really know whether it's asthma or not, but we have to go back. We're getting evaluated. We may have some spirometry testing which occurs, and that might be quite hard for a 2-year-old to accomplish if they're a young 2-year-old, and finding out if that airway disease is indeed asthma. Surgery involving the airway. Has the patient had some kind of biopsy, or have they had some kind of treatments? They may have had atelectasis, where they need some treatment to expand those alveoli and those respiratory sacs to open up and be able to receive oxygen and utilize it prematurely. So if they've had recent surgery involving the airway, check with the physician, see if it's okay for them to be coming to your office, first of all, for routine care, and then secondarily, if you need to talk with the physician about, is this patient healthy enough? How long has it been? Usually 6 to 8 weeks is when we can start seeing kids after they've had some surgery in their airway. It needs to heal up, and they need to be able to take care of that problem for the airway before you consider sedating them. Is the child preemies? I've said enough about preemies. If they are premature infants, we know that they're going to have these symptoms going on, reactive airway disease that's going on, and it's going to be important that we know that they're going to go on later on in their lives and have difficulties with their breathing, and when they get an URI, they tend to be much sicker than the kids who had the good 40 weeks and perhaps longer to be able to do that. So it's important to understand where they come, what's in their history, to expose them to environmental things like tobacco smoke. They're going to have a much more difficult time with their breathing, and the respiratory system is really working hard, and especially earlier when they're very young. So what about the asthmatic? In patients who deteriorate, despite usual therapeutic evidence supports individualized use of parenteral beta agonists, magnesium sulfate, aminophylline, leukotriene inhibitors, or positive pressure mask ventilation before intubation. And that's really important. We know that kids that are going to be ventilated, you've got a short period of time to put a tube down their throat, and so you oxygenate them quite vigorously before you begin to intubate, and then you have a couple minutes to get your tube into place. So close observations of the respiratory effort, the level of consciousness, and pulse oximetry serve as clinical correlates of pulmonary gas exchange. It's very similar in sedated patients because we are putting a tube over their mouth like a mask nasal breather, and it's important that they be able to exchange, get the oxygen in, and get it out. It's very similar that patients who deteriorate that are asthmatic is very similar to when we give drugs to sedated patients. Initial findings during an asthma exacerbation typically includes hypoxemia. They're just not getting enough air into the bloodstream, and hypocapnia, which means that the carbon dioxide that's coming out is not at the levels it should be. Hypercapnia is usually a later finding that reflects increasing airflow obstruction and fatigue because all the muscles are working to breathe, and it may indicate impending respiratory failure. So if you see hypoxemia, but you see hypercapnia, that means that a lot of the carbon dioxide is trying to leave the body. There's a lot of hydrogen ions that are being knocked off the hemoglobin, and it's detected in the brain, in the medulla, to tell the body to breathe faster because you get this pH decrease that's going on. And when that starts to happen, you want to make sure that this hypercapnia should be a signal to you, how long has this breathing been going on like this? And I see that we have low oxygen concentration here. What's been going on? Tell me how this has developed. And once you learn that they started with hypoxemia, couldn't get enough oxygen, were trying to breathe very fast, and now suddenly you have hypercapnia occurring and the heart rate's a lot faster, should be a clue to you that your patient's going to get fatigued very quickly. And when they start to get fatigued, it means you need to be there supporting the respiration, and you can ask the patient to take some asthmatic medication like albuterol, Ventolin, delivered by a metered dose inhaler with a spacer that allows 4 to 8 breaths every 20 to 30 minutes for 3 doses, compares favorably to nebulization, which is sort of a consistent amount of medication, and they use 2.5 to 5 milligrams every 20 minutes. And in patients with more severe asthma, the metered dose inhaler dosing can be increased to 1 puff every 30 to 60 seconds. That's sort of continuous nebulization can be instituted 10 to 15 milligrams per hour to improve symptoms. So when you see the patient is sort of crashing, you need to pick up those signs that I've highlighted for you here and notice that they'll start off with a regular breathing rate, but then suddenly they tend to go down, and then they're breathing really fast, they're getting really tired, and the pulse oximetry should tell you, along with capnography, what's happening with your patient. It's important you know how to use these monitors so you can bring your patient back, use a jaw thrust with the patient and bag valve mask, and providing the oxygen that they need, and using your albuterol inhalers. If it's an anaphylactic reaction, you're going to see the dermatologic addition to it, and that means that you need to go to your 1 to 10,000 or with intramuscular 1 to 100,000 amounts of 0.1 milligrams per kilo to be able to rescue your patient. Ipratropium bromide is another asthma treatment. It's a little bit milder than the albuterol, or you can use a nebulized solution, 3 doses of 250 micrograms each. The recommended follow-up dosing of 250 to 500 micrograms at 6-hour intervals is well tolerated. Ipratropium bromide is an addition if you have a severe asthma attack and you've added the albuterol and you've given some corticosteroids. You end up putting up some ipratropium bromide and magnesium to bring that patient back and treat them, and trying to get to the point when the EMS is going to come and help you. And typically, prednisone is given orally in a dose of 1 to 2 milligrams per kilogram once daily, and the usual maximum of 60 to 80 milligrams per day. This is given 5 to 7 days before this asthmatic arrives at your office for severe cases. For intravenous treatment, methylprednisone, sodium succinate, solumedrol is administered in a dose of 0.5 to 2 milligrams per kilo every 6 hours. The usual maximum is 125 milligrams per day, or hydrocortisone is given in a dosage of 2 to 4 milligrams per kilo every 4 to 6 hours. If you know this patient is going downhill, you are using the anti-inflammatories, using the bronchodilators, and the things that you need to make sure that this patient is stabilized. This is a regimen that you should have handy nearby if you're treating asthmatic patients. If you're involved in giving level 2 sedation to an asthmatic patient who's in the intermittent or into the mild asthmatic stage, and they go into a higher stage, then it's important for you to be able to handle and keeping this regimen on hand to be able to help them, and keeping current with the literature, so if they change this regimen, you know exactly what it is. Make sure that you use this and have this available to keep your patients healthy. Risk factors for death for severe asthma: they have had previous asthmatic attacks with respiratory failure, seizures, loss of consciousness, or intubation. If these patients have had seizures occurring in loss of consciousness and were intubated and brought back, these are risk factors that you might have for a patient who comes in with a history of severe asthma, or if you find those patients in the hospital, to consult with your respiratory physician to be able to make sure this patient is healthy enough to undergo sedations or even go back to the hospital. If they have a history of hypercapnia, metabolic acidosis, or pneumothorax from previous asthma attacks, it's important to know that you might have to boost up their system to be able to combat the inflammation that's going on and to reverse that hypercapnia and get the oxygen in there at a level that's going to keep metabolic acidosis at bay, or a pneumothorax with a previous asthma attack. Severe asthma attacks, despite long-term oral corticosteroid therapy, is important to realize on these patients, because you'll be seeing them for a long period of time, and you want to make sure that you're continuing to act with them appropriately when they come back with those diagnoses. Psychological factors, as we mentioned before, including mental illness, decreased perception of severity of dyspnea or disease. You want to make sure that if the patient can't breathe well, or you don't think that the asthma is that severe, be retrospective on this and think about what the non-compliance with asthma therapy could be, or substance abuse, or inner city residents are leading them to be high-risk patients from death from an asthma attack. So ensure that you gather this in your review of systems and you are clearly ready to handle asthmatic that gets into a higher level of severity. Reactive airway disease is a general term, as I've indicated, doesn't indicate a specific diagnosis, often mistaken as being another phrase to indicate asthma, but the two are not synonymous. Reactive airway disease is often used when asthma is suspected, but has not been diagnosed due to your child's age. We have mentioned this. Reactive airway disease may be used to describe a history of airway troubles, such as coughing, or wheezing, or shortness of breath caused by allergens. And that is kind of a history that you might want to gather when you're talking with your patient. They say, my child has reactive airway disease. Talk to them about coughing. How frequently do they cough? How frequently do you hear wheezing? Listening to the lungs. How frequently do they get out of breath? Are they limited for playing sports outside, soccer in particular, football? What's happening with them? Are they playing basketball? Do they get out of breath? And what are the kinds of reactive airway disease? Children under the age of 5 are typically diagnosed with reactive airway disease, and it can be difficult to come up with a concrete diagnosis of an airway condition at such a young age. Some conditions that may fall under the reactive airway disease diagnosis include asthma, bronchiolitis, which is a virus that causes wheezing or coughing, or airway hyperresponsiveness, a quick narrowing of the airways due to muscular contraction. Let's talk about the symptoms of reactive airway disease for a second. The symptoms of reactive airway disease are similar to asthma and allergies. It's important to keep a record of the symptoms in order to tell your physician. Symptoms may include they have trouble breathing, or they're coughing. They're sitting out in your waiting room, you're waiting, and your staff receptionist comes in and talks to you and says, Dr. Badger, so-and-so is here today, and I notice that they're coughing regularly, and when they start to laugh or something, or cry, it's causing some spasms. This is something that you might want to look at when the patient comes in to see you. If the patient is coming in for an appointment today, coughing or having gurgling sounds and coughing up sputum, reactive airway disease, you need to be ready to handle that, particularly if that patient has been scheduled. You want to listen to their lungs before you start that day. Reschedule if necessary. Wheezing while breathing, increased heart rate due to breathing difficulties, a runny nose. What is the character of the secretions that are coming out of the nose? Are they mucousy, or is it just clear liquids? Do they have chest tightness? Is it difficult for them to expand and take a deep breath? Ask them to take a deep breath for you. Is it difficult for that to happen? So you have some tightening down of the respiratory tree. Nasal congestion or copious secretions. Do they require endotracheal tube placement? Do they have a respiratory syncytial virus history? Are they emotionally or psychologically stressed? Are they using beta blockers, albuterol, aspirin, injected agents as part of a more generalized allergic reaction? Are they using those? So get all of this history, because bronchodilators and anti-inflammatory agents are good for mild, moderate, and severe. So if they're coming in and they're mild, they're using a beta-2 receptor agonist such as albuterol or terbutaline sulfate, 1 to 2 puffs every 4 to 6 hours. They have mild, and this is an ASA class 2 that you could treat. But if they happen to go into moderate or severe, you can see they're taking anti-inflammatory agents, corticosteroids, prevent mast cell release, oral theophylline, which is a bronchodilator with anti-inflammatory effect. They're using inhaled corticosteroids for moderate to severe asthma. Ipratropium bromide is used as a less potent bronchodilator, and when administered with albuterol has an additive effect. So seeing those both used at the same time should be your clue to this patient has moderate asthma disease. And finally, severe patients with asthma take corticosteroids or anti-inflammatory 2 milligrams per kilogram every day for acute severe asthma, plus oxygen. They may have CPAP that they're using at nighttime to keep them healthy. They may have a air machine that's clearing the air of any particles in their bedroom, possibly intubation, anxiety relief, which oftentimes they're taking that to keep them calm and relaxed in the face of severe asthma. And in some cases, mechanical ventilation is required. And we don't want to see that, certainly not in our offices. But they have albuterol, or they have a nebulizer that they use every night to keep their airway clear, along with corticosteroids, and carrying an inhaler with them during the day. These patients are at risk and certainly don't want to have an exacerbating condition when they come to your office. So evaluation prior to your treatment, practitioners should consider the following to determine how well the disease is controlled. The frequency, when was the last attack? What did you use to cure it? Did you have to go to the ER? How long were you there? The type of medications used chronically and during acute attacks, albuterol inhaler, ipratropium bromide, they using corticosteroids, and the length of time since the child was last seen emergently with acute asthma. Was the physical examination may include auscultation of the lungs, should be doing that if you plan to sedate somebody, observation of the rate and depth of respiration, how severe is it today when they're here, is the rate and depth of respiration greater than it was the last time you saw this patient? The use of accessory muscles for respiration, and that means the intercostal muscles are working very hard. You may have seesaw breathing, shortness of breath, and the patient is coughing. For severe asthmatic, consultation with a patient's primary care physician is recommended to determine if these physical symptoms that are going on and medications that they're taking, is it a severe asthmatic, and if so, you certainly want to delay the incidence of sedation with this patient. Children at high risk for perioperative respiratory adverse events. If they've had an asthma attack recently and they're coming in to see you, did they have a recent cold? Were they wheezing during exercise? Were they wheezing more than 3 times in the previous 12 months? Do they have a nocturnal dry cough? And again, do they have eczema and hay fever along with the asthma? If so, these are patients that are high risk for perioperative respiratory adverse events, and it would be wise to schedule them after they've seen their physician and are being treated by our medical colleagues. Patients with asthma on maintenance therapy, glucocorticosteroids, are adrenally suppressed and need to be supplemented on the day of the dental procedure by doubling the patient's usually daily double dose. This is what I mentioned. These children probably need to receive stress replacement doses, 60 milligrams per dose, 6 to 8 hours before, and again 1 hour before the procedure, although this is not generally agreed to by all authors. Neurologic disorders, psychiatric and behavioral problems. Patients who have attention deficit hyperactivity disorder are generally receiving medications to control their hyperactivity, to control them because they tend to be off the scales when it comes to being able to pay attention to what's going on in school, and that usually taking medications that's on a seasonal basis, and recommending that during their drug holiday, and typically that occurs in the summer, what medication have they been taking, what is the doctor taking to help them, and as children go, their dosages need to be increased generally, but once they reach maturity, 16, 17, and 18, then they may be stabilized on the dose, but recognize they'll take a drug holiday with their physician, and what is the doctor thinking? Are they thinking that they're going to, when they become a teenager, they're going to reduce their dose or just maintain that dose? So recognize these kids when they come in to see you, maybe on that holiday, and ask them if they're currently taking their medications and did they take it before they came to the office, in which cases they may be difficult to sedate because generally the ADHD medications are paradoxical in their reactions. You usually get an upper type of medication, and if they're being stimulated by their medication and you're trying to sedate them, it's really antagonistic to what you're doing in the office. Do they have autism? Are they high functioning, low functioning, average? Find out what's causing that. and any drug interactions that may be occurring with kids who are taking ADHD or autistic medication. They may become emotionally unstable because often the drugs affect the limbic system, because these kids are generally depressed because they know how apprehensive they feel when they're taking this medication, because it makes them feel like that, and often they're taking antidepressant medication along with the medication that they're taking for their ADHD. Kids who have seizures have increased drug metabolism. They are competition for the protein binding sites, and if the kids are taking seizure medication, it's important that they take that with a small sip of water early in the morning that you're going to do the sedations, because you don't want to have a seizure occur while your patient is sedated. Local anesthetic and narcotic sedatives affect the seizure threshold. It generally reduces the seizure threshold, so the narcotic sedatives plus the local anesthetic is controlling the seizure threshold, and if you're administering both of those for a patient that's coming in to see you, the patient's at high risk for having a seizure. Cerebral palsy are difficult to assess the sedation depth because your heart is very difficult to get a response from the CP that's accurate in terms of what's happening with the patient. Patient history and evaluation. GI disorders. Gastroesophageal reflux disease is a condition that affects some patients, and in particular patients who seem to be overweight. When they're overweight, they have a tendency to do some vomiting, and that vomiting may result in aspiration or swallowing or some loss of stomach contents, particularly if they have dysphagia. Dysphagia is uncoordinated swallowing, and oftentimes these three elements of GERD, vomiting, and dysphagia occur together. And when this occurs, it's difficult for them to ingest some food and make sure that that food stays down. GI motility disorders can occur, in which case it's going to make unpredictable bioavailability of oral agents and increases aspiration risk. Renal or hepatic disorders. Unpredictable drug elimination due to poor metabolism results in oversedation. When we don't know if the drugs are going to be metabolized or are poorly metabolized, it results in this increased plasma concentration of the sedating agent, and oftentimes consultation with nephrologist or gastroenterologist is important. Opioids should be used cautiously since they can cause sedation, constipation, and sudden encephalopathy effects. Since the clearance of these drugs in patients with hepatic insufficiency is decreased, the initial dose must be decreased. The intervals between doses should be increased, and some patients need to be continually assessed. Well, here are some questions that I think we should ask ourselves, and I'm going to give you a minute after each of these questions and see if you can come up with the answer. When is medical history and physical evaluation of the patient insufficient? Well, have you thought of an answer? Let's take a look and see what it might be. When is medical evaluation, history, and physical evaluation of the patient insufficient? The answer is when the recent history of the patient appears inconsistent with the present physical evaluation. For example, in a patient with intermittent asthma presents with a recent history of the use of an inhaler 2 to 3 times in the week, and the patient coughs periodically during his oral evaluation and appears pale with rapid breathing. If we look back at the history, we know that if the patient has intermittent asthma, then Recent history shows that there was an exacerbation in that consistency, and the 2 to 3 times in a week is not the history of intermittent, but for periodic. And so when the patient coughs and periodically during his oral evaluation and appears pale with rapid breathing, this means that ventilation is not occurring well, and that there may be some changes in the capnography and in the pulse oximeter with regard to this patient, and it's incompatible with the intermittent asthma. It could be that the intermittent asthma is changing, or this particular episode was difficult, and it means that the patient is here for sedation and they've had insufficient time for them to heal up, and therefore it's important that we delay continued treatment until this patient heals up and is ready. The next question: when does a physical inspection of the oral pharynx raise your suspicions of an elevated risk? What would the answer be? The question is, when does a physical inspection of the oral pharynx raise your suspicions of an elevated risk? The answer is when the patient might be overweight and the Mallampati score is 3, and upon lowering the back of the dental chair, the patient begins to breathe harder and faster. Ask yourself, if this patient becomes apneic, would you be able to provide an open airway or intubation or both? Well, if the Mallampati score is 3, that means we can barely see the uvula away from the hard palate, soft palate that's back there, and that lowering the back of the chair, the patient begins to breathe harder and faster. So that means that the diaphragm, the weight upon the diaphragm, is making it difficult for this patient. And ask yourself, if this patient becomes apneic, would you be able to provide an open airway, intubate, or both? The chances of the Mallampati score having sufficient space for doing intubation is going to make it really difficult. Therefore, this patient has an elevated risk, being with this score of the size of the tongue and the airway availability of space. And so this would be a patient you want to recommend going to the hospital or wait until the score changes. The third question is, when a patient provides a history of nebulizer treatment in the ER 2 weeks ago for moderate asthmatic condition, should you begin sedation? What would be an appropriate response to this question? Well, let's look and see what the answer is. The question is, when a patient provides a history of nebulizer treatment in the emergency room 2 weeks ago for a moderate asthmatic condition, should you begin sedation? The answer is, the patient's treatment should be delayed until the primary physician or specialist releases the patient for the treatment. Now that could be 6 to 8 weeks. And that's a good number to keep in mind, in that usually in the 6 to 8 week period, soft tissue injuries tend to occur and be healed over that time frame. So the response would be, let's wait for about 6 weeks before the time has elapsed. But checking with the primary care physician or specialist is important to do that. And if they say 6 to 8 weeks, or if they say whatever time that they decide upon, then this would be an appropriate interval before considering sedation again. If you need clarification on any information, send an email to the PACE Center at uthtmc.edu so we can clarify any of the information that we've provided for you today. Here we are at the references. We've completed Module 2, and I think you have been exposed to some time where we spent a great deal of time talking about asthma, as that is a very common illness that presents to our office, and if the patient is under control, such as in a very intermittent type of condition, then the patient has had the opportunity to be treated as an ASA2. However, if the patient's treatment needs longer than that, one of the ways to determine what is the appropriate time interval, what is the appropriate thing to do, is to go back to the references and read. Even though we spend a lot of time on asthma and its condition, we want to ensure that when that patient comes to the office, we are ready to handle not only the level for which our permit is, but also for deeper levels when the patient may be going into a respiratory event and the difficulty of reviving that patient and seeing the difficult breathing that's going on, the hotter and faster, and then suddenly we have an event that involves the cardiovascular system. We need to be sure that the respiratory events that occur with asthma or any other limiting condition is able to be handled, and we're ready to provide the treatment that's necessary in that level of sedation that we have, and even deeper levels of sedation, so that we can treat the patient until EMS arrives and everything will work out well. Thank you for paying attention to this sedation on Module 2. This completes this section of the course. It's time for you to take a short exam in order to complete the requirements for streaming video courses. Due to the nature of our subject content, a passing score of 80% is necessary in order for you to advance to the next section. Upon a successful completion of this exam, you will be visually informed that you have met the requirements to proceed. If you fail to answer enough questions correctly, you will be instructed to take the exam and a new set of questions will be provided. You'll have 3 chances to fulfill the requirements. If you're not successful, you will be instructed to review this section again. Good luck on the exam. If you're ready to take the next section upon completion of this exam, you will be provided a link to continue. If you wish to proceed at a later date, you will need to log in and no further payment is necessary since this is a continuum.